Hello, everyone, and welcome to the Down Syndrome Center podcast. As always, I'm your host, Dr. Kishore Balodi. And as always, at the end of every podcast, and probably including this one as well, we always send out a request for topics. And I love it when we get topic requests in. And this particular topic we're going to discuss today is one that a family had regarding feeding issues and deciding on whether or not things like G-tubes are needed. Now, you may not know what a G-tube is, and that's okay. We're going to be talking about that during this podcast. And so I'd like to introduce both of our speakers. Actually, I'll have you guys introduce yourselves. So we'll start with you, Sheri. Sheri, why don't you're a veteran to the podcast, second podcast now with us. Why don't you tell our audience who you are and what you do here at Children's?
Sure. Hi, I'm Sheri Rosen. I'm the lead speech pathologist with a focus on swallowing disorders. I have been working at Children's Hospital for 25 years, and I primarily work in swallow studies in the neonatal intensive care unit and the cardiac intensive care unit. That's where I focus most of my day.
Wonderful. Thank you, Sheri, for joining us again. For our listeners, if you want to hear the last podcast that Sheri did with us on feeding, predominantly with infant focus, you can find that podcast on our list. Just search for feeding issues and you will find it. And then we are also today joined by Dr. Mike Morowitz. Mike, why don't you tell our audience who you are, what you do here at Children's?
Sure. Thank you for inviting me to participate in this podcast. I'm a general and thoracic pediatric surgeon at the Children's Hospital of Pittsburgh with an interest in nutrition and gut bacteria of newborns and children.
Wonderful. Well, I would like to start off by just kind of giving a summary of what the email was that we got. And it's so helpful to have both of you on the podcast to talk about this with our audience. Essentially what was happening, the family had sent in an email saying that they had a young one who has quote unquote failed a swallow study, meaning that they were not able to swallow food successfully or the liquid they were giving them successfully. So discussions about G-tubes had come up. And so I wanted to kind of walk us through swallow studies in general, and then from there take us to what exactly is a G-tube and how is it placed and those types of things. So Sheri, why don't we start with you? Why don't you tell our audience a little bit more about what is a swallow study, like how are they done, who interprets them, all that type of stuff.
All right. So there's lots of different names for a swallow study. What specifically we are talking about in radiology is called a modified barium swallow study, or sometimes we just shorten it to swallow study. And sometimes in the local Pittsburgh area, we also call it a cookie study. It sounds a lot less intimidating for those toddlers and young kiddos that we're doing these on to tell them that they're getting a cookie rather than saying modified barium swallow study. So anyway, so all of those things are the same test. So for a modified barium swallow study, we typically start the appointment with interviewing the parents so that we get an idea of what the concerns are that the parents have for their specific child. And then we are able to kind of modify how we do the test based on what the concerns are. In general, for a swallow study, and what that means is we're doing a video x-ray. So if you get a chest x-ray or an x-ray of your belly, it's just one single snapshot. But for the modified barium swallow study, it's an actual video, so we can see in real time the function of multiple swallows. And by watching that, we're able to make sure that all of the food and liquid is going down the right way, and the right way would be down towards the belly, and making sure that nothing is going down into the airway. The children, depending on the age, are sitting in a little specialized formed chair to give them the support that they need. And then we would feed them in as typical of a manner as possible so that we're trying to mimic exactly what the family is seeing on a normal feeding. So what that means is if it's a baby that's laying in a more reclined position, then we would try to match that position for the swallow study. But if it's an older child that would sit upright in a high chair or something, then we would be able to manipulate that. And we use a special contrast so that whatever they're eating or drinking is able to show up on the X-ray.
And so, as you're doing this X-ray, if I'm understanding correctly, you're going to see that contrast from that liquid on the X-ray, and you're going to see kind of which way the fluid is going. And as we can see, actually, the data shows us pretty commonly in people with Down syndrome, infants, especially with Down syndrome, we see them often have where the liquid goes down towards the lung area as opposed to going down into the feeding tubes. And so give us an idea of like what is it that a failed swallow study would look like as you're doing it? And then how would you potentially manage a swallow study that doesn't go the way that we would hope?
So if we are seeing that some of the liquid is going down the wrong pipe, down towards their lungs, there's a lot of different things that we will try. One of the things that we will do is try to, if it's a baby, that we'll try different flow rates from the bottle. So it could be an issue that the bottle is just a little too fast or a little too slow. So we can sometimes modify what bottle or what nipple flow they are able to use. And sometimes just that type of change makes it so that the baby can manage the flow of the liquid appropriately and keep them safer while they're eating. If that doesn't work, we can add some cereal or some thickening agent to make the liquid move more slowly. And by having the liquid move more slowly, we can often find a successful level of thickening that will allow the baby to continue, or the child, if it's an older kiddo, we would do the same thing. We would thicken the liquid to see if that would allow them to swallow in a more organized, safe manner because the liquid moves more slowly. And usually with thickened liquids also, it's the liquid itself stays together better. If you spill a cup of water on your counter, this water is going to splatter everywhere. But if you spill a milkshake, it's going to kind of move a little bit more slowly. And that's the same concept as when you're swallowing. The thicker liquid moves slower and stays together better to allow them more time to organize to safely swallow.
And I think we see that quite a bit in our patients that we see in the Down syndrome center, where the slowing of the nipple flow rate or perhaps slowing of the liquid flow rate with thickening really makes a big difference. But what would be a result that you might see on a swallow study that may end up getting that report that says we don't feel that this child is necessarily safe to eat orally at this time?
So there are approximately 4 different levels of liquids that we will often try. And then in terms of food, there are different levels of thickness of food as well. So the only time we would say that we do not think the baby or the child can have anything to eat by mouth is if we try all of those consistencies and they're having some of each of those consistency either go down the wrong pipe or we're seeing something that makes us believe that over the course of a full meal, even though we may not see that on the swallow study, over the course of a full meal, we suspect that it would go down the wrong pipe. So if there is absolutely nothing that we find in all of those different consistency options, then we would say we do not believe that this child should be eating anything by mouth.
Wonderful. And thank you. I mean, I know that can happen. Thankfully, it's relatively rare for us to see it get to that level. Usually there's something that we can do, as you had discussed earlier, but we do sometimes find that the child is found on a swallow study to not be safe to orally feed because of what you've discussed. And in that situation, we would get our surgeons involved. And so, Mike, I'd like to bring you here into the podcast as well. just in a basic sense, can you give us an idea of what is a G tube? Like, what does it stand for? And why would somebody perhaps need one of those placed?
Sure. So as anybody that's been around the hospital knows, there are tons of types of tubes and catheters that people are exposed to. And the name G-tube simply refers to a gastrostomy tube, which is one of several types of feeding tubes.
Okay. And we were talking about a failed swallow study being one reason why we might need one. Are there other reasons where you might get consulted as a surgeon for someone to say, hey, let's consider putting a G tube in this patient?
Yes, definitely. So the history of placing tubes in children and adults for extra nutrition goes back, more than 100 years. And essentially, it's something to consider whenever somebody can't take by mouth the amount of food or nutrition that they need to survive and thrive. And so there are a number of different scenarios where that can be helpful. It's important for people to understand that on a temporary basis, an option is often to put a tube through the nose or the mouth down into the stomach to temporarily provide access to the intestinal tract for nutrition. But this is not a great long-term scenario. And so the types of scenarios that we frequently encounter are people that, as Sheri mentioned, have difficulty swallowing, so it's not safe for them to swallow, or that sometimes there are children that have what's called oral aversion, where they can safely swallow, but they just, for a variety of reasons, don't want to do so. There are also patients that are critically ill and sedated and intubated on a mechanical ventilator and therefore can't eat. So there are a lot of different reasons that we would want to place a tube to help a person get the nutrition that they can't take by mouth. And way back when, it used to be that people would get their nutrition from the bottom. And that's in modern medicine, that's no longer fortunately done. And that's where G-tubes come in pretty commonly.
So before we go into kind of how G-tubes are placed and things like that, I'm assuming that there are some other studies or tests that are needed before you would be able to place a G-tube. But what would be required before that would happen?
It's pretty common to look at the anatomy of the esophagus and the stomach in a radiology study prior to G-tube placement. A commonly utilized study is what's called the upper GI test, which is pretty similar to what Sheri described with the cookie study. And that's because many children that require G-tubes do have some structural changes of the stomach, which are helpful to know prior to G-tube placement. But some people would actually refer to that as something of an old-fashioned piece of advice, and many surgeons nowadays would actually proceed with G-tube placement even without those studies. Okay.
So when you get this child, we've decided to place a G-tube, family has been in agreement, and you get them into the OR to place it. Give me an idea, or give our audience an idea of what does that look like? Is this a very invasive surgery? How do you actually physically put a tube into the stomach?
Sure. G-tube placement is a super common procedure or operation in all hospitals, but especially children's hospitals. That said, it is considered a major operation. It's very, very important that people understand some risks, such as risks related to anesthesia or risks of infection after surgery. But that said, they're quite low. And I think that when your child or family member needs a G-tube and is at especially a busy children's hospital, you can be really confident in going forward with the procedure. What you can expect is a surgery that is done almost always under general anesthesia. We can talk about the exceptions if you're interested, but almost always under general anesthesia. And that means a baby or child is asleep and anesthetized. And essentially, the goals of the surgery are to find the actual stomach within the abdominal cavity underneath the skin and the muscles of the belly, and to bring it up to the skin and the muscles of the belly and stitch it there and put a tube right into the inside of the stomach. The stomach itself is kind of essentially like if you imagine like a balloon that can be inflated and stretched, and that's where it holds our food when we eat, and that can be brought up to the skin surgically. The technique of doing that can vary. Most commonly in the U.S., this is done with laparoscopy, cameras and small instruments, but that's not necessary. The main thing is to safely find the stomach, bring it up to the skin, secure it there, and place a tube so that nutrition can be delivered through that tube into the center of that water balloon inside the child's belly.
And is the recovery period, is it a long time? Does it take months for them to recover, days for them to recover? What do you see typically?
Sure. So in a very common scenario where somebody comes into the office and electively schedules that procedure, we generally see children stay in the hospital for 1 or 2 nights after surgery. And children are amazing in terms of their recovery for surgery. If it were me, it would probably take a good 6 weeks to recover, but most kids are acting like themselves within 1 or 2 weeks. We generally recommend avoiding exercise or swimming for the first month or so after surgery. And after that time, children can usually resume life as it was before the procedure.
When they go swimming eventually, actually, this is a question that comes up often. Is there some sort of cap that goes over the tube so that we're not seeing swimming pool water going into their stomach?
Right. So it's a fairly simple process of protecting the tube and protecting the swimming pool water. And first, I should mention that many families are really ingenious in coming up with their own solutions to problems like swimming and bathing and everyday activities. But most commonly, we see that people will put an occlusive adherent dressing over the G-tube itself. And it's important for people to realize that once the G-tube has been placed and healed within a few months, there's pretty low risk from any sort of activity that your child might be pursuing from having the G-tube. So, I mean, I really don't think there's any activity that I know of that having a G-tube should prevent, a child from pursuing.
Great. And I was hoping you might be able to address, because many times when the discussion of G-tubes comes up, another procedure is often mentioned at the same time called a fundoplication. And the name that people may be familiar with perhaps is a Nissen fundoplication. What is that? And how do you determine if somebody needs that?
Sure. So you're absolutely right. That's a very common scenario where either a pediatrician or neonatologist or speech pathologist says, can you look at the possibility of doing a fundoplication or a so-called fundo along with G-tube placement? There are a lot of details to be said about that, but basically the take-home point is that this is for children or adults that have really bad heartburn or reflux, such that when they have food in the stomach, it starts coming back up into the esophagus or the mouth, or in worst case scenario, into the lungs. And the fundoplication is a surgical procedure that doesn't eliminate that from happening, but it certainly minimizes it. And the reasons that this can be beneficial are first to prevent food from going back up into the lungs, but also so food will go downstream and get absorbed, and so children can grow better with the nutrition that they need.
And I think one thing that families will ask about is, after the G tube is placed, does this mean that they can't eat by mouth anymore? Because what we see very frequently is perhaps the child is having a hard time gaining weight because they have a cardiac issue, or perhaps the swallow study was just a moment in time and they're going to recover their ability to feed later. Does having a G tube mean that they'll not be able to orally feed, or perhaps if they have a Nissen that they cannot orally feed? Can you give us an idea of what that looks like?
Yeah, that's a really important question. Like I said, having a G tube, and it's true for a fundoplication as well, shouldn't prevent any child or person from pretty much any activity that they want to do, and that includes eating. So, the goal would be, in many cases, for people that receive G tubes, that eventually they can get back to eating to the point that the G tube can be removed, and we can talk about that separately. But between the day that the G tube is placed and the day that the G tube may be removed, they can certainly safely eat by mouth. And in many cases, the G tube remains essentially a backup, so they can get extra nutrition if not enough can be taken in by mouth. Now, it is true that in some rare cases, placement of a G tube somehow makes reflux or heartburn worse than it was before. And so, for people that look online, you may see reports of feeding getting worse with G tube placement. In my experience, this is a very rare event, but it's a reasonable consideration. And so that, therefore, oftentimes, if we're on the fence about whether or not to do the Nissen fundoplication, we'll often do it just to eliminate that possibility that somebody's feeding winds up being worse.
Okay. Yeah, that's an important point to keep in mind. And I guess, Sheri, I wanted to come back to you at this point. So I'm assuming then you probably in your practice will see children who have a G tube placed, and the family might be saying, hey, we're starting to get the sense that they're orally feeding better. Are these kids that ever come back to you to get another swallow study done and try to confirm perhaps that their feeding pattern has improved?
Absolutely. So first, I do want to say that very frequently on those swallow studies, we are able to find something that the child can eat. So even when they're not able to get all of the hydration or all of the nutrition, that's when we can have them orally feeding and then have the supplemental nutrition through the G2. Anytime we have a swallow study that we make any modifications in the child's diet, either by thickening or limiting or restricting anything that they eat, we would always want to repeat that swallow study. And the amount of time that we would want to happen to pass in between the studies is extremely variable based on medical factors, the age of the patient, and the developmental level. So it would be hard for me to kind of give you a time frame, but we would absolutely want to follow any of these kids, at least in feeding therapy, ongoing feeding therapy. And then at Children's Hospital in Pittsburgh, we have a wonderful feeding clinic that we would continue to monitor the children and the children's progress. And that would help us to guide what the timing would be, so that we would expect the best results on a repeat of the modified Burn Swallow study.
Wonderful. So let's say we have a good best case scenario here. A child had a G2 placed, perhaps had not passed a swallow study or had some other feeding issues, got a G2 placed. And here we are, let's say 6 months later, the family is saying, hey, we haven't really needed to use the G-tube. We've been cleared for completely full oral feedings for those 6 months. She's been doing great. So we get to this point of making the decision to remove the G-tube. And Mike, I'll take it back to you at this point. Is that another surgical procedure, or what all is involved in removing the G tube?
Another great question. So removing the G tube usually follows one of two pathways. For about 75% of kids, the G tube can be removed in the office. Most of the G tubes that we use have a balloon on the inside of them. And so I know I described the stomach as a big balloon, but inside that big balloon is a tube with a little balloon that keeps it inside the body. And so by removing the fluid within the small balloon, the tube itself can be removed very, very, very easily. And at that point, the issue that we look out for and talk to families about is most of the holes where the tube had been placed, which is in the left upper part of the abdomen, that hole will usually scar down and close within a period of a month, which is a pretty amazing response that the human body has after removal of a tube. However, in roughly 25% of people, especially that have had the G tube for years or more, that hole will not close on its own. And as a result, when somebody drinks or eats, either liquids, solids, or gastric juices will come out through that hole. And therefore, another surgical procedure, which can be an outpatient elective procedure, is required to close that hole. But as I mentioned, that's the minority of cases. The vast majority close easily, and it's very easy for families to take care of that situation.
Wonderful. Wow. Okay. Well, thank you. This has been really helpful information for our listeners as well. Before I close our podcast, I just want to open it up to say if you guys had anything else you wanted to add or anything you felt would be important for our families to know, right now would be a great time to tell us.
I'll add that this is a super common scenario, both in the inpatient and the outpatient setting, both for children with and without Down syndrome. And I wanted to make the point that it's very, very common that families have some reluctance about proceeding with G-tube placement. And if I were in their position, I would feel the same way. But I have never had a family that I know of regret placement of the G-tube. And by contrast, have known many, many, many families that were thankful that they did eventually take that step, because it can help so much with nutrition. And again, it's a big step, and we don't discount the risks involved. But once it's appropriate, and we have people like Dr. Velody, overseeing that decision with us, it tends to be a positive step for kids and their families.
That's a great point. And I think it's something that we definitely at the Down Syndrome Center here in Pittsburgh, when we look at national data compared to our own data, we are very cautious about any kind of surgical procedures that potentially could be necessary. And G-tubes are relatively rare within our population. But when we look nationally and worldwide, we do see quite a few more G-tubes in people with Down syndrome. So I think this is such an important podcast topic. Sheri, it looked like you had something you wanted to add to this as well.
Yeah, I was just going to add that there's so much pressure on families to make sure that their child is growing and getting everything that they need. And sometimes by having that G-tube, it takes that pressure off of the family and the child, so that what can be and is often a very stressful time of the day can go back to the way it's supposed to be. And it can really be a positive and bonding experience, because the parents know that the child's going to get the nutrition and the hydration that they need, and that what they are eating can just be about enjoyment and having having that special time together as a family.
What a great point. Yeah, we definitely think about that quite a bit. And when you have a stress or anxiety situation, especially if it's around food, you may have a medical issue, of course, beginning the situation with feeding, but then moving forward, some of those stress and anxiety around feeding can even contribute further. So I love that point that it takes that aspect of it away and allows the feeding to become more of a pleasurable experience. I love that. Yeah. Well, great, Mike and Sheri, I appreciate you guys so much coming on the podcast and sharing your expertise with our families. For our families that are listening, again, like I said at the beginning, this was a podcast topic that came from one of you. So I really appreciate that person for reaching out to us. If there are other topics that anyone would like us to cover, please reach out to me at downsyndromecenter@chp.edu. And we'd be glad to find speakers like we did today to help address that topic. Also, if you'd like to join with us financially at the Down Syndrome Center, including in aspects of this podcast as well, we would love to have you join us as well. You would just go to givetochildrens.org/Down Syndrome Center. But until next time, bye-bye.